All right, let's talk about something you almost never see anymore, but definitely need to know for your exams, the barium follow-through. I know, it feels like a lost art, right? But here's the thing, it is absolutely essential for your medical boards. So think of this as a quest. We're gonna go rediscover its secrets together. And when I say quest, I'm not kidding. The author of our source material here really leaned into it. He frames his journey like some epic adventure, surviving malaria and 5 bouts of gonorrhea, all just to bring back these ancient fluoroscopy secrets. It's hilarious, but it perfectly sets the tone for what we're about to dive into. So you might be asking, why are we even bothering with this, barbaric ancient practice? Well, the answer is simple. It is still fair game on your board exams. They fully expect you to know this stuff. So this isn't just for fun. It's a mission-critical briefing for anyone who wants to pass. And here's the cool part. All that effort paid off. Our intrepid explorer didn't just come back with a few random tips. Nope. He unearthed a whole system, an ancient, powerful 3-step method. The story goes it was found in the scrolls of Zuthal. This thing promises to cut right through the confusion and make sense of it all. And here it is, the secret map. It's just 3 steps. Super simple. 1. Evaluate the folds. 2. Look for a mass or any tethering. And 3. Evaluate the distribution. That's it. This is the framework we're going to use to tackle basically any small bowel case they throw at us. Okay, let's jump right into step 1, evaluating the folds. Seriously, the way the folds look is your first and maybe most powerful clue. You're just asking simple questions. Are they thick? Are they normal? Are they totally gone? Just answering that one question starts knocking suspects off your list immediately. This table breaks it down perfectly. Think of it like 2 different families of problems. On one side, you've got the regular, uniform thickening. This stuff is usually from big systemic issues, ischemia, low protein, venous congestion. But on the other side, you have the more gnarly-looking irregular, nodular thickening. These are your classic villains: Crohn's, Whipple's, lymphoma. See? Just by figuring out which family you're dealing with, you're already halfway there. All right, step 2. Now we're on the hunt for masses. So you looked at the folds, now you're scanning around. Is anything pushing the bowel? Is anything pulling it out of place? This is where we start looking for that classic sign, tethering. So what exactly is tethering? The best way to picture it is like something is pinching the bowel loops and yanking them towards a mass. That's the look. And here is a super high-yield pearl for your exam. If the process is extrinsic, meaning outside the bowel, it'll cause this tethering, but the mucosa itself will look fine. If the problem is intrinsic, like a tumor in the wall, it's going to mess up the mucosa. That's a huge distinction to make. Okay, so our source material has some, let's just say, memorable ways to remember things. And for Whipple's disease, you get this gem. Look, it's designed to be unforgettable. It might be a little unconventional, but I guarantee you will not forget the classic patient demographic for Whipple's on your exam day. This leads us right into a classic board exam gotcha question, telling the difference between Whipple's and pseudo-Whipple's. On imaging, they can look exactly the same. You'll see thickened folds, little nodules in the jejunum. The whole key is the clinical context. Pseudo-Whipple's, that's from a MAC infection in an AIDS patient with a really low CD4 count, like under 100. The tiebreaker isn't on the image. It's the acid-fast stain. It's going to be positive for MAC. They love to test this. Okay, so we've got the ancient method down. Now it's time to collect the treasure, the high-yield loot. This is going to be a quick, rapid-fire rundown of all the trademark signs and buzzwords. These are those ant mini findings, the ones that are so classic you know them the second you see them. You absolutely have to know these cold. First one up, celiac sprue. The buzzword you need to burn into your brain is fold reversal. And it's literally what it sounds like. The jejunum, which is supposed to have all these nice plush folds, gets totally flattened out and starts to look like the ileum. At the same time, the ileum tries to pick up the slack and gets more folds, trying to look like the jejunum. The whole thing just flips. It's wild. And sticking with celiac for a second, another big one is the moulage sign. Moulage is a French word for like a wax model or a cast, and that's exactly what it looks like. You get this dilated loop of jejunum where the folds are just gone. It looks like a tube of wax. Once you see it, you'll never forget it. Okay, this next one is a dead giveaway. If you see cobblestoning, your brain should scream Crohn's disease. So what's causing it? You've got these deep linear ulcers that are cutting through the mucosa. What's left behind are these raised little islands of inflamed tissue. And yeah, it looks just like an old cobblestone street. It's a total hallmark of Crohn's. All right, time for a classic mnemonic, Meckel's diverticulum and the rule of twos. This is pure memorization, but it's super high yield. Let's run through it. It's in 2% of people. It has 2 types of ectopic mucosa, usually gastric or pancreatic. It's found 2 feet from the ileocecal valve. It's about 2 inches long, and symptoms usually show up before age 2. Just think Meckel's rule of twos. Got it? Okay, Gallstone ileus. For this one, you need to know Rigler's Triad. 3 things. Number 1, pneumobilia, that's just air in the biliary tree. Number 2, a small bowel obstruction. And number 3, the gallstone itself sitting somewhere it shouldn't be. Now here is the board exam trap, so listen up. They will try to get you to confuse Rigler's Triad with Rigler's sign. Rigler's sign is totally different. That's free air. Do not fall for that trick.
And speaking of not falling for tricks, this brings us to the final piece of advice from our guide. When you see one of those classic distractors, like the Rigler's Triad versus sign thing, the author's advice is to just quietly, while you can read it. It's all about spotting the trap, acknowledging it, and just moving right on with confidence.
So there you have it. We've been on the quest, we've learned the ancient 3-step method, we've collected all the high-yield buzzwords. Now it is time for the final trial, the boss battle, if you will. Let's see if we can put all this ancient wisdom to use on a classic case. Okay, here's the scenario. You've got a 55-year-old man. He comes in with malabsorption and joint pain. The barium study is done, and it shows thickened, irregular folds and these distinctive sand-like micronodules in his jejunum. So think about it. You've got the patient demographic, you've got the clinical presentation, and you've got the classic imaging findings. Put the pieces together. What's the diagnosis? I'll let you solve this one.